This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard, of Cardiology Specialist of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Welcome to our podcast. Today we're on, AFib, and it's about perfecting the heartbeat and what are the mechanisms to do that and what's the best way to do that. And with me tonight, I have a very good friend of mine. I mean, we've been friends for many, many years. Dr. Ibrahim Hanna, who's an electrophysiologist at Ascension St. Vincent in Birmingham. Ibrahim, welcome to MyHeart.net. Thanks for taking the time tonight.
Thank you for having me, Alain.
So, of course, atrial fibrillation, I mean, this is like, the dream of electrophysiologists because there's so much that can be done, but also so much to be discovered and so much that we don't know. So it's really kind of a wide open field. But when we talk about atrial fibrillation, we always talk about the four pillars in AFib, and we talk about how to prevent AFib, and we talked about that. We had a wonderful podcast together. I welcome, for our listener to listen to it. It's about perfecting the beat and guarding your heart. Make sure that your heart, remains in a good heartbeat. Number two, we have to prevent stroke, and there's many ways to do that. It probably should be the subject of the next podcast, which should be either the use of oral anticoagulation versus special device that we can put in the heart, that can protect against a stroke without the need of oral anticoagulation. And today we're going to discuss rate control versus rhythm control. So we got our work cut out, Ibrahim. And first, let's start by definition. What are we talking about when we talk about rate control versus rhythm control? What is that?
So, Anna, as you alluded to, AFib is a big part of any cardiac electrophysiologist's practice. It's the most common rhythm we see in clinic on a daily basis. And so, over the last 25 years or so, there's been a big evolution in the way we think about AFib. So back in the early 2000s, there was this big question about whether it's enough to just rate control patients. So somebody shows up with AFib. Generally speaking, patients who have AFib who show up in our clinics typically have fast heart rates. There are a few instances when they show up with controlled heart rates, but for the most part, patients who have AFib as a first encounter with the healthcare professional will come in with an elevated heart rate. And you and your listeners probably know very well that a normal heartbeat normally is in the range of 50 to about 100 beats per minute. And so patients with AFib can show up with heart rates way above 100 beats per minute, even sitting down. And their heart rates could be 160 beats per minute, 180 beats per minute. And that, generally speaking, is a big problem. It is usually felt by the patients. So most commonly, patients come in and say they feel their heart fluttering. But even if they don't feel the fluttering, they ultimately, develop untoward consequences from unrestrained fast heart rates, such as congestive heart failures and what have you. And so when we talk about rate control, what the goal of the therapy is to bring that fast heart rate down back into a more normal range, so closer to 80 beats per minute at rest, as an example. This is in contrast to rhythm control, which is a strategy that is typically deployed to help patients return back into normal rhythm. So two very different strategies. Rate control is to prevent fast heart rates while the patient is still in AFib. Rhythm control is an attempt to bring the patient back from an abnormal rhythm, which is AFib, back into a normal sinus rhythm.
So rhythm control, getting the patient back into a normal heartbeat. How do you do this? I mean, how do we perform rhythm control? I mean, talk about maybe the different ways that we can achieve that. And maybe you could kind of at the end tell us why maybe rhythm control may be better.
So if patients show up in AFib, there are really two patterns of the arrhythmia. One is called paroxysmal AFib, where the patient goes in and out of AFib on their own. There is another pattern called persistent AFib when the patient comes in AFib and stays in AFib until we get them back in normal rhythm. So as a first step, if somebody is showing up into the clinic with paroxysmal AFib, where the AFib is self-terminating, then what we try to do is to use medications, for example, called antiarrhythmic drugs that help the patient stay in rhythm once they've converted back on their own into normal rhythm. In patients who have persistent AFib, we have to intervene as a first step to get the patient back in rhythm and then deploy the strategy that will help them stay in rhythm. Normally, we get them back in rhythm through a process called an electrical cardioversion, where we put paddles on or patches on the patient's chest. We give them a little medication to make them sleepy and comfortable, and then we push a button on a device that delivers the shock to the heart to restore normal rhythm. But that on its own is only a temporary measure. It does not prevent the next episode of AFib, and that's why we have to put them on antiarrhythmic drugs as an example to stabilize the rhythm and prevent it from coming back. So rhythm control is achieved through either rhythm medications, like I mentioned just a second ago, or very commonly nowadays through a procedure called an atrial fibrillation ablation procedure. And through that procedure, as you're familiar with, Alain, we put catheters into the patient's veins, go inside the upper chambers of the heart. We try to map out the areas that produce the abnormal electrical impulse and try to cauterize them. That really is what an ablation is. And so these are really the two strategies. You either use antiarrhythmic drugs or you use a procedure called an ablation, or sometimes you can use the combination of both of these approaches to achieve durable normal sinus rhythm.
So that's very good. Let's say, for example, my heart rhythm problem, AFib, comes in and out, and I'm very symptomatic. I feel my heart, racing really fast. It gives me even some chest discomfort. But every time I go to the doctor, it's back in normal rhythm. So, but it's been documented. We did a Holter, and finally, I'm consulting with you as a patient. You say, okay, we're going to need to do an AFib ablation. What does it mean for me? Let's say you schedule, for example, next Tuesday. What should I be expecting as a patient?
So what the standard approach for an AFib ablation, especially for patients who have paroxysmal atrial fibrillation, is to have the patient come in on an empty stomach. That's kind of sort of part and parcel of every cardiac procedure that we do. The patient undergoes an echocardiogram where we put the ultrasound camera, if you will, inside the esophagus for about 5 minutes to take close-up pictures of the heart, make sure that there are no blood clots already present in the heart, because if there are any, we cannot do the procedure. There's a big risk of stroke if there is a blood clot. So assuming that the heart is clean, there is no evidence of a clot, then the patient goes under anesthesia. As I just mentioned earlier, we put catheters through small puncture holes in the vein, typically the one that goes to the right leg. And then we go inside the heart with these catheters that have the ability to measure the electricity in the upper chambers of the heart. And then once we do that, we have a pretty good sense about the extent of the abnormal signals, where they're coming from. The cornerstone of an AFib ablation, especially in patients who have the type of AFib you just mentioned, which is, paroxysmal AFib, patients go in and out on their own of the arrhythmia, then the cornerstone is to do what we call a pulmonary vein isolation procedure, where we go around the veins that drain the lungs, and then we ablate all the signals around them to effectively neutralize the electricity coming out of them. And that usually is sufficient to produce durable sinus rhythm in about 75 to 80% of patients. The procedure takes about an hour and a half to do. We send patients home roughly, in general, the same day, unless we get done a bit later, or the patients are having, difficulty with waking up from anesthesia. And then we do a regular routine follow-up with them over a period of a few months, just to make sure that they're healing well from the procedure. And ultimately, the goal in patients with paroxysmal AFib is to get them off the antiarrhythmic drug if they are on one. And we find this approach to be highly successful. It is not a perfect intervention. It does not cure everybody that has atrial fibrillation. Even patients who are otherwise healthy, have paroxysmal AFib, can at times not respond as well as we like them to the procedure. But in comparison to rhythm control via antiarrhythmic drugs, there is a significant benefit from an AFib ablation over antiarrhythmic drug therapy, especially in centers and in the hands of operators who have a high enough volume that the risk of the procedure becomes relatively small. That is always in our mind a risk-benefit proposition. So anytime we approach a patient with a procedure, we're always trying to determine whether the risk that they're gonna take to have the procedure done is fully justified by the potential benefit they can have from that procedure.
So you mentioned that let's say after 2 or 3 months, when the healing is all done, a lot of times you can come off even anticoagulation if you're young and you have very low risk. What happens if it comes back, let's say a year or two later? Can you do a second ablation? Can you do a third ablation? And what are the rates of success in those cases?
So Alain, as a general rule, we tell patients that there is a 10 to 20% chance of the need for a redo procedure. If we do an AFib ablation and we get good results for a period of time, and then the patient has AFib again, we tend to think that maybe there is a problem with reconnection of the veins. As I mentioned earlier, we tend to go around the veins and disconnect the electricity. That's kind of the cornerstone of the procedure. But even, with the advanced technology we use nowadays and the care we put into making sure our lesions are solid lesions and they're, achieving, as best as we can assess it, the destruction, if you will, of the tissue that we're targeting, there is still a chance of recovery of conduction. And so we would go ahead and do a second procedure. We sometimes do find, in fact, that there is reconnection. If we don't find reconnection, that in general tends to signify, progression of the disease, that there are certain triggers that, are coming from outside the veins. And that usually means more extensive work than we started doing with the first ablation. In patients who have AFib that is more persistent, meaning it's a more stubborn form of AFib, where it's not coming and going on its own, like we were just talking about, but it's somebody who has AFib that just stays and just doesn't want to go away until you cardiovert them, then you give them antiarrhythmic drugs and they don't respond. Then if we do the first ablation procedure and we see shortly after that they have another recurrence of atrial fibrillation, then we sit down and take the time to figure out whether it's worthwhile for them to go through a second procedure. And if we do a second one that's more extensive and we still see atrial fibrillation, then, it's a bit discouraging at that point. We like to see atrial flutter, for example, as an indication of some progress in our ability to control the arrhythmia. So there is no cookbook solution, no algorithm that applies to everybody. And in that sense, it's as much of an art as it is a science still, kind of trying to figure out what is the best strategy for rhythm control for any particular patient.
Obviously, you tend to, do rhythm control, bringing back in a normal heartbeat, if it's fairly kind of early into the onset of atrial fibrillation. But is there any particular, and of course, if they're very symptomatic, they feel they're in AFib, they feel the palpitation, they can hardly function, they're short of breath and they have chest discomfort. But is there any particular group of patient that you would want to favor rhythm control, possibly even through AFib ablation, as first-line therapy?
So as a general rule, and our practice has evolved over the last 15, 20 years, whereby patients who have paroxysmal AFib, who are highly symptomatic, as you mentioned, and who need to be on some sort of therapy for rhythm management, we tend to approach them with an AFib ablation as a first step, because the success rate of the procedure is particularly high in this patient population and definitely dwarfs the success rate that you see with antiarrhythmic drugs. So as an example, antiarrhythmic medications at 1 year will give you a 30% chance of being in normal rhythm. AFib ablations have a tendency to give you about 70 to 80%. So you can tell that there's a huge gap in success between both. So patients with paroxysmal AFib who are symptomatic, as a first line, we tend to approach them with an AFib ablation, unless they have comorbidities or other things that makes the procedure a bit unsafe. They have severe COPD or other things that, makes the anesthetic, general anesthesia a bit of a problem. But aside from the symptomatic patient, we also see a group of individuals who come in with AFib who are totally symptomatic. They have no idea that they're out of rhythm. They don't have any palpitations, nothing of that sort, but they show up with significant structural heart disease. So they drop their LV function. And, you and I have shared patients like this, in 2023, somebody has an EF of 60%, they come back to see you a year later and, lo and behold, they're in AFib with rapid rates. You repeat an echo and their EF is like 15, 20%. And these patients tend to do great with rhythm control. Once you get them back in rhythm, we see a dramatic improvement in LVEF. We even see a change in the severity of mitral regurgitation. So we kind of reverse the structural heart disease. So that's a patient population where we tend to be very aggressive with. And we find that, maintaining rhythm control is very, very important. As I said, they may not be symptomatic with the AFib per se. They ultimately become symptomatic because they develop congestive heart failure. So patients with low ejection fraction, patients who have structural heart disease, severe MR, et cetera, as a result of asymptomatic AFib, and patients who have early AFib, and there's a study that is kind of sort of very popular now and is referenced a lot in AFib talks. It's called the East AF study. They took patients who had early onset AFib, so AFib that was diagnosed within 12 months of enrollment into the study, and they treated them with rhythm versus rate control. And there, the rhythm control arm did significantly better. Again, this is also to remind your listeners that AFib comes in stages, and AFib progresses over time. And from an EP standpoint, as a cardiac electrophysiologist, it is very, very important for me that the referring physician who identifies atrial fibrillation sends the patient early to us so we can intervene early. The success of any of our interventions and the impact of any of our interventions is substantially higher and more impactful if we manage to treat the disease in its early stages compared to getting the patient in the later stages of AFib. Ablations are less successful, rhythm control is less successful, and the impact may be also less measurable.
Yeah. Well, you mentioned patients with heart failure, basically where the AFib really affect their LV function. How about the young athletes, or how about the young people where they're really kind of they want to be functional, they're hardworking folks, and the AFib has really become kind of a nuisance. Do you actually tend to do more AFib ablation in these patients?
That's great. Yes, in fact, you have hit the nail on the head, as you say. This is a patient population that usually tends to not tolerate antiarrhythmic medication. So athletes, as a general rule, have two issues. One is that the resting heart rate is usually pretty slow because they're very fit, and so you really don't have much room to start antiarrhythmic drugs because you will push their heart rate even slower at rest, and then these antiarrhythmic drugs tend to become proarrhythmic, as we call it, as patients become more bradycardic. At least some of them do. And then the other issue is that athletes tend to achieve very high target heart rates, right? I mean, they're just going beyond. I mean, they're pushing physiology to an extreme, and so they have to generate this gigantic cardiac output, and so they increase their heart rates. And so if you dwarf that increase, if you limit it by giving them antiarrhythmic drugs, then you also impact their ability to perform at the high level they want to perform at. So as a general rule, these patients tend to not tolerate. I mean, even if you try it, they'll come back to you and they will just complain about it, and you won't be able to give them the antiarrhythmic drug. So yes. This is definitely a group of patients where an AFib ablation is in most instances the first and best choice.
It seems like over the last 20 years, there was not that much difference between rhythm control, particularly with the AFFIRM trial, and now more and more, people seems to be evolving toward rhythm control, particularly with the study you mentioned, East AF. Despite the fact that, in East AF, a lot of patients had a lot of antiarrhythmics, and also the advantage was not very high, compared to, rhythm control in terms of like prognosis and how they did. But how do you see the future of AFib treatment? I mean, do you feel ablation is going to become just kind of like routine as the the first treatment of choice for all patients with AFib? Is AFib ablation becoming easier with new technologies coming on, or where do you see the AFib treatment headed?
So that's, I mean, you really summed up in a few words the landscape of how AFib evolved, the therapies evolved. So as you mentioned, AFFIRM and then RACE AF, both of these studies really showed back in the early 2000s or indicated to some extent that rate and rhythm control are equivalent. Of course, there are a lot of issues with these studies, and we can go over those, but they're quite exhaustive. Suffice it to say that since then, especially with the more recent data, and some of the data out of Cabana, the per protocol analysis, as well as the East AF.net, all of these things all of these studies tend to suggest that maintenance of sinus rhythm is important in a large group of patients. How we achieve that is really the question. The problem with antiarrhythmic drugs, as I just mentioned, is that they're fairly ineffective at what they do. I mean, really, the most effective medication that's available right now is amiodarone, which gives you a much better success rate at maintaining sinus rhythm compared to all the rest of them. But that medication also has its own problems. It has the potential for serious long-term side effects, So, when you look at the guidelines, it's not really a first-line agent for rhythm control, except in patients who have, HFrEF, patients with reduced ejection fraction or congestive heart failure. And the landscape has not changed. Antiarrhythmic drugs have really not changed a whole lot. The most recent one was dronedarone, and it really is a very, mild medication, if I could put it that way, in terms of its ability to achieve rhythm control. So AFib ablations have become so important because they're so much more powerful at achieving rhythm control, at achieving durable sinus rhythm. And as you mentioned, the landscape has changed also on the technology side. When we started doing these ablations, in the early 2005, 2006, as I was training, as a fellow at Emory, we started doing those. The technology was more clunky. It was much more complex procedure than what we do right now. The procedures were longer. The mapping tools were significantly less effective, and that is constantly changing. There is a lot of innovation in that field. What I will say is that AFib ablation is not for everybody. So I just want to make sure that I mention that. And that's why it's important, to consult with your cardiac electrophysiologist about whether you are a good candidate for it. And I'm not trying to make a blanket statement that it's the first, order of business in everybody who has AFib. But if rhythm maintenance is desired, ultimately AFib ablation is a very important tool. The success rate of the procedure has not changed dramatically over the years, despite all the evolution in the technology, but the safety of the procedure and our ability to perform it in a controlled, safe environment has also improved significantly. We are more efficient at doing the procedure as well. And so in the right hands, it is a very important tool. As you mentioned, technology has evolved. We use thermal energy with RF. That's kind of sort of been the workhorse for many years. Then there was cryo, which is like using ice cold or freezing tissue essentially to destroy it. And now there is newer technology called pulse field. That's kind of sort of what it is. It's non-thermal injury to the myocytes through perforation of the membranes. Again, the technology is evolving. The procedure is becoming shorter and safer. And so we look forward to what the future holds, but nobody really knows what the future holds because, every time we think we've achieved the milestone, then, you turn around and there's another one that's, being conquered essentially. So, which is very exciting in this field.
So much to understand, even though we've been doing ablation now for a while, ablation keeps getting better, but if it keeps coming back, in some of these patients are a little frustrating. And, I think a lot of research still needs to be done. Well, Ibrahim, I got to thank you. I mean, we talked about, how to prevent AFib. Now we talked about, how to treat AFib, rate control versus rhythm control. And we have another podcast, coming up in the future is how to prevent, stroke, whether blood thinners are best for the patient or maybe, some of the devices that are available, like left atrial occlusive device. Obviously it's not for everybody. We're going to try to discuss, who's a candidate for that and who's not. And at the end of the day, we want patients to do well without a stroke and feeling better, with good quality of life and no heart failure. Ibrahim?
Live a lengthy, good life. Thank you, Alan.
Very good. Thank you very much. Ibrahim Hanna from Ascension St. Vincent. Thank you very much. Appreciate your time.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.